So main aims of a LeDeR program are, as I said, service improvement, so improving the services for people with learning disabilities and autistic people. Reducing the health inequalities people with learning disabilities and autism face. We know that there's significant health inequalities this group of people actually faces. Reducing the premature deaths and early deaths in people with learning disabilities and autism. So those are three key kind of aims of this program.
It came out of some concerns that were raised in an inquiry into the premature death of people with a learning disability. The purpose of it was to look at whether there were lessons that could be learned or whether there was anything specifically that was becoming a trend.
People with a learning disability and or autism die a lot earlier than the normal population, and there is a lot of health inequalities around that, and anything that we can do to improve that, I think, is for the best for those people with a learning disability.
One of the best initiatives that have come out of the LeDeR programme locally has been the introduction of the health passport. I'm very proud to say that as a system we were nominated for a Nursing Times Award on a national level for the contribution that this health passport makes. But actually what the health passport does is brings together in one simple document all the key requirements an individual will need when they present themselves, for example, at a GP surgery or accident and emergency department, so that their transition into receiving care and treatment is as smooth as it possibly can be. Just in the same way that you or I will be able to articulate that, it takes that pressure off in terms of having a documented record of what those needs are.
Locally, there's definitely been improvements around annual health checks in GP surgeries for those that are on the learning disability register. We have done things around improving training for staff around learning disabilities and autism, and also sharing some of the learning that comes out of the reviews and how we can improve patients' experience when they're with us.
The LeDeR will produce a national report yearly so that we look at the trends, and there is evidence that some of the areas that were a concern, so people dying of aspiration pneumonia, has reduced. In South Staffordshire we're also producing a training tool for staff, particularly in social care, around eating and drinking and the issues with people having dysphagia, which is a swallowing problem.
In 2022 report, we've seen that around 50% reduction in deaths from pneumonia in people with learning disabilities and autism. So this program has already started to make a significant improvements in the care and the quality of care these people actually experience.
Raising the awareness of the needs of individuals with learning disabilities has always been a real challenge, and I think the LeDeR programme has helped us to bring that forward and make more and more people aware at every level throughout health and beyond what the potential impact of their actions will be, and enabled us to really continue to pursue a high quality service for these individuals.
Once a death is reported, it is allocated to a reviewer for initial review. So there's two stages. So it's initial review where they see if they need further information on the death. They speak to a family member, and they might speak to a GP or review GP records or hospital records or care records to see if there were any lapses in the care. If they think that review needs further investigations or further looking into, then a focused review is commissioned.
So I'm involved with the governance panel with the LeDeR programme as the independent chair. We host the meeting once a month, and we normally bring 2 cases to be reviewed and to look at in more in-depth way to look at the learning and actions that need to come away from that case. So we'll have the reviewer of the case that will go through each case individually, give us a real good picture of what happened, a bit about the person, how they were, the conditions that they had, the disabilities that they had. And we look at their death and what happened around that death, things that could be improved, and elements that work well.
We discuss improvement required locally and pathways which need improvement. Also, we identify the good practice and we share with our GPs and other clinical colleagues and health and care colleagues. We share that learning.
I think with sort of young people that have got autism, They are very apprehensive about going into a situation in a hospital and talking to strangers. So I think the atmosphere into which you walk has got to be more relaxed. The consultant or the nurse or whatever has got to acknowledge that person has learning disabilities and try and make things as easy and as comfortable as possible. We didn't feel quite as safe. It was a stranger environment. And also because of his age, a lot of the consultants that you got in touch with wanted to speak to James. Well, because of his autism and his learning difficulties, he would expect me to answer, or he didn't understand what they were asking him. He has a very high pain threshold. He can be poorly and you don't really know he's poorly, and he can't actually explain that to you. And we found sometimes some of the consultants didn't understand that.
You do feel a bit out on the limb sometimes, because there might be something might arise and you think, I could just do with talking to somebody about that. And you don't know who to go to. You don't want to bother the GP surgery. But Michael has a lot of medical issues now as he's got older. He's had terrible problems with his thyroid. Once it was overactive, then they gave him medication. If it was underactive, then it was overactive again. Then he developed double pneumonia, and he was very, very poorly. We were seen, and he was in resus within about 15 minutes. You know, he'd survived, he got over it. But when we were discharged from hospital, it was as though a safety blanket had been taken out from you, because you were sent home, and that was it. They'd done their bit, yes, they had, but you're on your own out there with no sort of follow-up.
There's lots of things of the way that people talk to people with learning difficulties that it's just training, really. The professional has got in their mind what they want to say and starts using ridiculously long words. And I'm having to say, could you explain that bit again? And again, if that happens too many times, the general could just get fed up. She's not going to listen. She's not going to follow. And that feeling that she has comes out of the room with her and into the car. And then when you're at home and you try to do the exercise or whatever it is that they want you to do, she has bad memories of it, and she's reluctant to do it and to cooperate.
Through my role as a trustee for a child of mine, I am actually on the panel, the governance panel for the LeDeR programme, and I've done that now for sort of 18 months or so. Found it very interesting. You see lots and lots of people with various titles and whatever, and they're all talking about what they're trying to do to make things better. We work through the review cases, which is brilliant, and try and come up with ideas to improve care going forward. But it's also beneficial then when you hear that it's gone to the next level and then certain things have happened, like the health passport becoming more commonly used, the annual reviews and comments that have come back on annual reviews and what should be done in annual reviews. Those sorts of things are good. And I have learnt a lot. But I've also found that I've transferred it through to James's daycare provision here at Futures Together.
We have a disability nurse who I think is my absolute saviour. Sometimes if there's bad behaviour that you're dealing with, she sees it from another viewpoint and can explain it and come up with ideas of how to deal with it. Everybody should have a learning disability nurse in the community to be able to just call on, just to give support and backup. When they go above and beyond, it makes you feel that you're not alone.
Michael's been having his yearly disability review, which the surgery instigates. I never have to chase that, which is a good 3/4 of an hour where they check everything, which I think is absolutely fantastic. But you get that all in one medical, in one consultation with a doctor who sits and listens to you. And it's just a nice thing that one person is sitting there taking all this information and checking him over. But it is that one medical once a year where they're taking on board Michael as a person. And I do find that invaluable.
Well, I'm hoping that health inequalities will reduce, that, as people become more aware of the needs of people with a learning disability or autism, that those will reduce, that more people will have an annual health check, and those issues that people die prematurely from will be picked up sooner.
We've had a lot of interaction from staff since they've done the training and wanting to learn more. We've had a medic recently who's contacted our learning disability specialist nurse and asked if they could shadow her during the day to see how they can make improvements in regards to caring for people with a learning disability when they're with us.
We're looking to how we can innovate and be more creative locally to make sure we take the maximum opportunity and maximum learning. And a really good example of that is now we're an integrated care system. We collaborate with partners in the local authorities and in the police force, for example, and using those collaborative networks that we have, we'll be able to work very closely with housing and with our police partners to make sure that the continued spread of the learning from the LeDeR programme goes beyond the boundaries of the health service.